Good morning, everyone, and welcome to Real Talk Cancer Unmasked, a podcast by the Youth Medical Network in support of the Singapore Cancer Society that aims to inspire, inform, and ignite hope for cancer patients, survivors, and caregivers to live well with cancer.
Welcome to Real Talk Cancer Unmasked, a podcast dedicated to informing and inspiring people to join us in the fight against cancer. I am Darius Lim, President of the Youth Medical Network. Since May this year, the Youth Medical Network has been a ground-up community promoting public health and health literacy. Our 255 youth members help to engage with the community through various initiatives such as health talks and podcasts to raise awareness on important health issues, share inspiring stories, provide peer-to-peer support, and more. We are honored today to have the support of the Singapore Cancer Society. The Singapore Cancer Society is Singapore's leading charity dedicated to minimizing cancer and maximizing lives by joining in the fight for a cancer-free community.
Today's podcast is going to focus on the journey of a cancer diagnosis. A cancer diagnosis usually happens behind the closed door of a doctor's consultation room, away from the public eye. We want to bring the experiences, emotions, conversations, and challenges to the forefront and take a deep dive into everything that goes on behind the scene. I'm looking forward to finding out more about what actually happens when a cancer diagnosis is made and what it means for the patients, the medical team, as well as the caregivers.
We are honored to have on the show today Dr. Hendrik Tan. Dr. Tan is a radiation oncologist at the Fiona Stanley Hospital. Dr. Tan also undertook a clinical research fellowship at the Stony Brook Odette Cancer Center in Canada. In the course of his work, he has encountered many cancer patients and caregivers. Welcome to the show, Dr. Tan. Thank you for joining us today. To start things off, I'd like to talk a little bit more about cancer that we commonly hear, whether it's in the media or in medical dramas, and that is brain cancer. At some point of time, I think everyone has either experienced headaches or migraines. Can you please share with us exactly how headaches come about and how do they affect the body?
Yeah, thanks, Darius, and the team for inviting me to talk to you guys today about cancer in general and what to expect. So just pertaining to your question, Darius, so with regards to headaches, I mean, we all get headaches and it's very common. I mean, it could range from severe, not so severe headaches, but ultimately, when we talk about more significant headaches is when you have ongoing headaches that's really bad and really long and persistent despite simple medical management, if that makes sense. And with just, turning to the brain tumor patients, typically they do present with headaches sometimes. And that's partly not due to, blood vessels, closing up or opening up that's causing migraines or headaches. It's more to do with the presence of a tumor in the brain. And in the brain itself, our body is designed in a way when you have a foreign mass or a kind of like a growth in the brain, what happens is the brain will then react to it by swelling up. And when the brain swells up, you can imagine your skull being like a barrel that it's, when the brain swells up, there's really no place to move. So when you get that swelling effect, so patient can get swelling and nausea and vomiting, and that's actually a really common sign for a patient that presents with brain tumors. And aside from that, it also depends on where the brain tumor sits in the brain. So for instance, if the brain tumor sits at the front of the brain, on the frontal part of the brain, that is in charge of patients' cognition. So they may present with headaches along with confusions. If their tumor present in the temporal lobe, which is on the side of the brain, patients will come in with headaches potentially and seizures. If the tumor locates in the back of the brain, where the visual centers is located, then patient will present with sometimes headache, nausea, and visual symptoms. And if the tumor presents at the bottom back of the brain, which is the balance center, patient will then have neurological symptoms like imbalance, along with headache and nausea, which are the common presentations. So those are a few signs to look out for, but they varies, and it could be very, very different from patients to patients when they come into the hospital.
And Dr. Tan, can you share with us, when someone is diagnosed with brain cancer, what exactly has happened in the person?
Well, when they get diagnosed with brain cancer, if you talk about, physical, emotional, kind of like mental standpoint of the patient, but when they come into the hospital at the very beginning, we as doctors we look for clinical signs and symptoms, and when patient comes in with those symptoms, it could be so non-specific, and without a scan, without patient undergoing surgery for biopsy, you can't really say, yep, patient comes in with seizure and headaches, and that's going to be brain tumor, because it could be anything else. It could be things that are benign and non-cancerous. So when patient comes in, a thorough checkup is needed. So whenever patient comes into the hospital, usually they come into the emergency department, the first thing that they're going to get will be a scan. And that scan will be a CT scan to start off with, because it's easy to access CT scan. And then when there's any abnormality picked up on the CT scan, patient would then proceed and get an MRI scan. And that's a better way of visualizing the brain tumor. And then, the standard workup will be, bloods as well. So patient present with seizure, there could be imbalance in their body's salt level, for instance. So that's something that it will be checked up as well. And then finally, if the scan picked up that there is a growth or mass in the brain, typically at that point in time, patient would then be discussed in the meeting or get referred on to a neurosurgeon for targeted biopsy. And when surgeon comes in and look at taking a specific tumor out from the brain, they'll always try and remove the whole thing if possible. But as mentioned earlier, the brain is such an eloquent organ in our body. Sometimes if you have brain tumor that are seated very, very deep within the brain, it's actually very challenging for the surgeons to get to and resect the entire tumor out to its entirety. So in those settings, it's a kind of risk-benefit scenario. Most of the time, the surgeon would just say, we'll just go in and get a biopsy to know exactly what's happening, and then we'll talk about management plan. So the aim of the game is to try and get to the bottom of the diagnosis without causing too much harm of the patient straight off the bat.
Thank you for sharing, Dr. Tan.
That's
I
right.
think some of our listeners would also be curious to know, currently, how much do we know about potential causes or risk factors for cancer? And how much, in fact, do we still not know with today's technology?
This that's a question that I ask myself every day. I mean, there is certain cancers that are very prevalent and goes down the genetic course, such as breast cancer. Occasionally, if you have abnormal gene, there's some gene that predispose patient to getting prostate cancer, pancreatic cancer, and some other genetical syndrome that carries that risk in the background. You might have heard of our celebrity Angelina Jolie, who has BRCA gene mutation. For her, in their lifetime, there's a 30-50 chance, 70% chance of her getting breast cancer. And hence, in those patients, it makes sense for them to act up front. And in Angelina's case, she went and had bilateral mastectomy. Anyway, long story short, going back to your question earlier, it varies, right? For breast cancer, we know it runs in the gene. And patients who presents with younger, so patient who comes in younger, who has lots of family history. So we're talking about first generation family history of cancer, certainly in Australia. So in those cases, when they get discussed in the meeting, there is a genetics team present as well in the meeting, and they will usually put a hand up and say, hey, this patient is suitable for genetic testing, and we'll put them through genetic testing to figure out what's actually going on. But then the thing is that you might ask, the cancer has really been diagnosed. Why do we have to do genetic testing? It's more for their offsprings and their family members. If they carry a specific gene mutation, it's good for their family members to know that, you know, it's there. So they're also aware to keep out and look out for symptoms associated with cancer. Pertaining to brain tumor, because we talked about brain tumor earlier on, no one actually really knows. And brain tumor could happen in multiple ways. So one of which will be a primary brain tumor. I mean, we still don't really know what actually causes them. When patient comes in and asks me, why do I get it? You know, half the time I just said, you know, it's just one of those things that we don't know, you know, and we just have to deal with what we have in front of us. And there's other kind of brain cancer there is associated with a primary cancer. So for instance, patients with lung or breast cancer, with disease that is spread into the brain, that is a different thing. So we know the root cause of it is that patient has an underlying cancer diagnosis outside of the brain and now has developed a brain tumor related to the original cancer. So that will be the causative pathway. But for primary brain tumor, it's something that is we're still not sure at this point in time.
And Dr. Tan, what happens to a patient medically or physically when he or she goes through the various stages of cancer? So from like stage 1 to the more advanced stages.
Yeah, I mean, if we talk about brain cancer in general, we don't actually, you know, stage patient, you know, but with the normal staging that we're aware of, like stage 1, 2, 3, and 4, we look at grading. So we're talking about primary brain tumor, so it's very different. So there's a lot to talk about brain tumor, but we're just going to talk about the primary brain tumor. And the classical one will be a cancer called glioblastoma multiforme. And that's the worst of the brain cancer that any patient can get. And we do see a lot of it here in Perth, West Australia, because we do have a really good neurosurgical department here that does a lot of brain tumor. So we do see a lot of cases. But long of the short, with primary brain tumors, it comes in with grading. Most patients, when they present, they either have grade 2, 3, or 4. And the prognosis varies widely. So, for instance, patients with grade 4, let's just go for the worst case scenario. The median survival is whereby if you have 100 patients with glioblastoma multiforme, so the bad brain tumors, you line them up from patients who live the longest to patients who live the shortest, right? Let's say there's 100 patients, you line them all up. The person in the middle is called median. So the median survival without any form of additional treatment aside from surgery, it's only about 4 months, 4 to 6 months. And if you give them chemo and radiotherapy, that lifespan prolonged to about 18 months. Still not very good, still pretty bad, right? And then let's just flip the coin around and talk about grade 2 or 3 tumors. If you have specific markers in that brain tumor, patient could live 7, 14 years, you know, they live a long time. So some patients survive forever, like grade 2 cancers, for instance. They still need extra treatment, but they will live for a very, very long time. So it's a wide range. So when they come in, when they sit down, then we'll have a long and hard discussion. For the grade 2 and grade 3 tumors, it's a lot easier to talk about it because they do survive a long time. But the grade 4 tumor, it's often very, very difficult. It's hard when they come in after being so well, working, and then one day they present with seizure. The next moment they've been told that they've got a grade 4 brain tumor, and now your lifespan is only 4 to 6 months without any treatment. So that's really, really challenging. So for the patient, it could be an initial fright, and then they go through that 5 phases of grief or a cancer diagnosis, where they get the front end of shock, and then they get anger, and then they go through that phase of bargaining, and then that phase of finally accepting the cancer diagnosis and the treatment itself. I'll stop at that because I think you probably have more questions to ask me, just so that we can just have a bit of a flow to the Q&A session.
Let's transition and start looking at various treatment options. And I'd like to
Yes.
touch on surgery. Surgery can be a potential cause of treatment for cancer in its initial stages. But is there a place for surgery in those later stages of cancer?
Yes, yes. So if you're still going to talk about brain, I can change gears and talk a little about lung. So going back to your question, right, of stage 1, 2, 3, and 4, that is relevant for lung cancer. So for the listeners, when you have stage 1 lung cancer, it's usually when you have a very small primary, and no spreading into the lymph nodes or into the other organs. So in those cases, if the patient is well enough, you can just be treated with surgery, and then once that's all taken out, you're done. You just go under surveillance, 6 monthly surveillance, and then that's it. Stage 2, stage 3 disease is a little bit different because they now have lymph nodes involved. So there's a lot of new trials that's come in. So I'm just going to introduce the term modality. All right, modality is the form of treatment modality. So you can have one modality of treatment to dual modality to 3 modality. So often as the stages increases, say for lung cancer, the modality increases. So let's just, for instance, grade stage 2 and 3 lung cancer, for instance, those patients would have dual modality. So it could be a combination of chemo first and immunotherapy up front, followed by surgery, or surgery up front, followed by radiotherapy. And then stage 3 disease is, again, the better stage 3 disease, chemo and immunotherapy up front, followed by surgery. And the more aggressive form of stage 3 disease typically get treated with chemo and radiotherapy. And then the stage 4 disease, for instance, that's when patients have spread of disease to all of the organs around the body. In those cases, I usually tell my patient that chemotherapy remains the backbone treatment, because if you have spread of disease, the cancer cell is going into your bloodstream already. So chemotherapy makes sense, or immunotherapy makes sense in those settings, because that's drug treatment that works systemically throughout the entire body. So that will be their backbone treatment. And radiotherapy will only come in for treating sites that are painful or symptomatic, or if they develop a brain tumor, we'll treat that as well. So things like that. But it changes from single modality treatment to multiple forms of treatment. And then just rewinding back to stage 1 lung cancer, we're talking about lung cancer now. Patient with a small tumor who are not suitable for surgery, we can also irradiate that with radiation therapy. Radiation has come a long way. We did a lot of that when I was in Canada, and we do a lot of that here in Australia. And it's a very effective treatment for patients who are non-operable candidates. They can get targeted radiotherapy over 4 sessions, no pain, no needles, just radiation, and then that's it. We ablate the tumor. The control rate is really high, 90+%. So for those patients, those are viable options for them. And then I know we're going back and forth a little bit. Going back to your brain tumors, the aim of the game when your patient presents with brain tumor is to try and remove the entire tumor if possible. And then, as I alluded to earlier, if the target of the tumor is located in a spot of the brain that is very eloquent, let's say it's located along the motor strip. So if the surgeon goes in and take out the tumor, it could crank a bit of a nerve or the strip of the motor function, and patient can be paralyzed. So it's a very fine balance. Ultimately, the aim is to safely remove what the surgeon can remove. This is pertaining to brain tumor, and that's all stages. If they can take it out safely, they take it out. If they can't, they just take to the most they can take out, and that's it.
Thank you, Dr. Tan, for sharing. We'll now be moving on to our second topic, where we will talk more about the journey of a cancer diagnosis.
Okay, hello everyone. I'm Charlene, one of your co-hosts for today, and I'll be taking you through our next segment on how the patient and the medical team make treatment decisions on cancer diagnosis, what are some of the considerations involved, and what the patient can choose to do. So, Dr. Tan, can you share with us some insights about your role as a radiation oncologist and some of the patient profiles that you usually see?
So just going back to that question, where my role comes in, most of the time when patient comes into my clinic, they've already been diagnosed with the cancer diagnosis, right? Because we're an oncologist, so a lot of the front work up to this point has already been spoke about. However, there's been multiple times whereby the patient comes in not knowing what's actually going on. And that is the most challenging part. So a lot of the time, patients already been informed by the referrals that they have X and Y cancer diagnosis. And when they come in, I just have to talk to them about the treatment process. But there has been times where patient, let's say, has had a surgery done to, let's just talk about the brain once again, the brain. And from there, what they found is they don't know what's actually happening because, like I said earlier, whenever there is a brain tumor, you could think about benign causes which are non-cancerous causes or cancerous causes. So when they come in, they're not really sure what sort of cancer they have. And then when they rock up, they were like, all right, tell me what's going on. And then I'll sit them and spend a lot of time talking to them about different cancer diagnoses, talk about the natural history, how they usually present, talk about potential causes, if known. And then from there, we'll just talk through the treatment management plan. So for let's just go with the worst case scenario. So for those patients, I really feel very bad for them, especially the younger patients. So we do see a lot of younger patients now with primary brain tumors that are, we're talking about the grade 4, which is the worst of the worst. And you can imagine when patient comes in, the one that hits home the most and affect myself as a clinician, is younger patients who have young families. So young parents with young kids. Those are the ones that are tricky because when they get diagnosed, you tell them the timeline, median. Median is, we talk about how we determine median, but some patients do live longer than that. Some patients live shorter than that. So for them, when you first tell them, all right, even with all of the treatment we can offer you, your median survival will just be prolonged from 6 months to 18 months. For some people, there might be a win, right? Because 12 months is great. But for most people, that's not nice. Like imagine if you're in your 40s and you've been told you have 18 months to live. That's just not nice news to hear. So patient will go through all sorts of things. Patient will break down crying in the room. They get fear. They're anxious about the unknown. They don't know if the treatment's going to actually work. And then they go through that entire grief and loss process. So they know they grieve because they've been diagnosed with cancer diagnosis. And then that loss is that, that loss of sense of normalcy. So they're all working, they day in, day out, everyone has a routine. And now that routine has been broken because of a cancer diagnosis. Potentially they couldn't work. And then they get disrupted by isolation, that feeling of being alone. And you might not fully understand that, but when you go through cancer, no matter how well supported you are, at the end of the day, you're the one going through that emotions. And then that could also put a strain on relationship, because they tend to just lock themselves in, and not tend to want to open up, talk about family and friends. And that role around the house will shift as well when that happens. So if you say a mom or dad who has been diagnosed with cancer, one of them could stop work, for instance, then there'll be financial strain and concerns in the family because the other partner would then be picking up that role. There's definitely a shift of dynamic in the family. And then when they go through, and then in Australia, for instance, there is both public and private health. So, I mean, some patients comes through the private sector would be concerned about medical burdens and so on from cancer treatment. But then that aside, even if you're treated in public land, because you have been taken away from your work, you don't have a source of income. So there's going to be a financial strain to the family as well. So there's a lot of different things that goes through the patient's mind when they get hit by that cancer diagnosis. And our role is to really get them through slowly, a step at a time.
All right. So can you share with us more, probably about how you walk them through this like conversation and this process, and like how you can help them out?
Yeah, so like I said, we talk about the natural history. So I think patients just want to know, because we're all, when we have a lot of information now everywhere, widely available online and so on, and I guess patients nowadays are more educated. Before they come in, they've done some reading beforehand to know exactly what's going on. So that educating the patient is so important and it's so crucial in the front end, the diagnosis. You got to really tell them, sit down, let them understand the diagnosis, what sort of expectation. You decipher out the treatment option for the patients. Tell them the different options and practicality, the logistics and potential side effects. So they want to know all of the details. You put them all on the plate, and then you let them then decide and make an informed decision into that treatment paradigm that you've drawn out for the patients. Because you could tell the patient, all right, this is what you need, X, Y, and Z. But then you got to cater to the patient's, I guess, personal belief, the quality of life, and some other, life consideration to work out the best package for that patient. So it's not like a standard bread and butter come in and then this is what you get, that is what you get. So some patient who comes in who are frailer, older, again, using brain cancer as a prime example, they patients who are older, you may want to look at truncating the treatment, making it shorter and more condensed, so it's less toxic for the patients. So there's a lot of things from the clinician standpoint to cater the best treatment, to get patients the most out of the treatment management, and also not impact too much on their quality and cause too much side effects. So instead of patients getting signed up for 6 weeks of radiations, for instance, to bring older, slightly frailer patients will tend to condense that down to 3 weeks. So there's bits and bobs. Instead of giving concurrent chemo radiotherapy, so chemotherapy given at the same time as radiotherapy, you can look at giving them sequentially. So if you do radiotherapy first, followed by chemotherapy. So there's a lot of things we can cater so that the patient knows that we're really thinking for the patients and we're not trying to impact on their quality, as much as we can.
So you just talked about truncating treatment, right? But what about for those who have really advanced cancer and they need to consider stopping treatment? What are some of the considerations that you take into account then?
So for patient who needs to stop treatment, then I believe that comes from the patient themselves. You do see some patients who wants everything done, who are not very realistic. You just really have to sit down and be very detailed to them, involving their loved ones and their family members to make that informed decisions. And a lot of the time, when we're talking about stage 4 cancer, they go through certain lines of treatment, and then at some stage, there will be no lines left, and then patient would feel like defeated and very depressed, and so there's the whole family. And then it depends on what you get out of the patient. So at that point, you didn't have to switch gears and talk about focusing on quality rather than quantity, and that's how I always put it. And what we want to do is make sure the remaining lifespan that the patient have is as painless or as possible, or as comfortable as possible. Then you have to involve other team members like palliative care team to come in, and those guys could help patients with management and so on. Certainly, radiotherapy can be done for painful bony lesions, for instance. So we do that as well for patients to get them through, make sure they're pain-free and painless towards the very end of that disease course. And some patients, you may feel some patients are really aggressive. They're still in that denial state, and they really just want something done, right? So in those situations, even though you have nothing to offer, but you can give them a chance and a hope. You talk about potentially, talking to another person, because at that point they hit a brick wall, right? They just need a bit of an out. And in those situations, sometimes you can talk about, why don't you go see one of my other colleagues? Why don't we look at potentially some clinical trials things like that, to see if we could just give them that hope, you know. And that's really important to respect that, because some patients do want to push and make sure that we have actually crossed out every single thing on the list before they're willing to let go. And that is something that I find most tricky. And you'll get that feeling from the very beginning, just from when you're talking to the patients and family, you know the expectation of what they want to do with the treatment. But then you do have some patients who are more accepting of it. I mean, it's not an easy thing to do, right? To be accepting of your fate that you're gonna pass on in the next 3-6 months, right? But then some patients, they get exhausted. And I think that's what turned the coin around for them, is that they go through so many lines of treatment, and then to the end, nothing's really working. And then they just accept the fact that they cannot be sick anymore. And then they're just willing to let go. In those situations, you just get everybody in. You get the clinical psychologist in, you support them at home, make sure they're pain-free or painless and as comfortable as they can towards the very end of their life.
You place quite a bit of emphasis on like the patient and the family and how it's their choice to make, right? So I was curious about whether you've ever encountered an instance where the patient made a decision that the family didn't really like agree with, and like what it was like and how the medical team helped resolve this conflict.
It's actually the other way around. Most of the time is what the family wants and what the patient doesn't want, rather than what the patient wants and the family doesn't want, if that makes sense. So it's there's a lot of time you're treating the family. And let's say if you're dealing with a older patient, elderly patients, who there is, if you give them more treatment, they could be so sick, and that would have impact on the quality of life. So in those situations, but then the patient's family is still very, I guess, aggressive with their treatment management, and they do not really want to let the patient go, and that's completely understandable. In those settings, we just want to make sure everybody's on the same page. So we will try and coordinate a family meeting. Everybody's involved will be present. So ourselves, the allied health team members, could be anybody from nursing staff to social worker, for instance, if they have social work problems, social situation at home, it's not ideal, and so on. And then they get palliative care team involved. And then we have a really nice and meaningful discussion about what the expectation is from the clinician standpoint, and then sit down and talk through the different viable options with the patients. Usually things settle down after the family meeting, and so that we're all on the same page. So that's how we actually resolve the problem. Yeah.
Right. I just want to go back to talking about the diagnosis of advanced stages of cancer. I know many would think that like being diagnosed with like late stage cancer is a terminal diagnosis, but do you necessarily think that's the case?
Yes and no. Yes and no. So most of the time, if you have stage 4 cancer, you know that your lifespan will be somewhat limited. But then it's trying to maintain that open communication with our patients. And again, that communication is really the key. You have an open dialogue, you create a space for the patient to really express their feelings and their thoughts and concern and preference openly to you. So then you get that bond at the very beginning. And that's so important for patients to embark on this cancer journey. So once that's all lined up, they know the expectation and so on. And then going back to your questions of stage 4 cancer in general, I've definitely seen more patients do live longer with stage 4 cancer because chemotherapy and immunotherapy and targeted therapy, it's all very good nowadays. It could actually prolong patient life for many months or even years. For those listeners who do not know, immunotherapy is basically a drug treatment that is given through the vein for the patients, kind of like 2-weekly cycle, for instance, and it actually basically induce your own body's immune system to attack the cancer cells. So that's a very targeted form of cancer. and then cancer treatment. And then there is also another form of treatment called targeted therapy, and that's to do with some driver mutations. So we talk about mutations. So when a patient have say lung cancer, for instance, we're switching gears, talking about lung cancer. When patient have a biopsy, there is something that you can look at, targetable mutation. So whether or not the patient has any form of mutations that you can target with a drug. And there is a lot of drugs available now for patients with targetable mutations. And that has proven to improve patient survival in the long term. So going back to your question, Xiaoling, yes and no. We do have some stage 4 cancer whereby you do not have any other options available, and no patient will just, passed on in short months. But then for the more lucky patient with quote unquote stage 4 cancer with say targetable mutations or suitable for immunotherapy, those patients can live a long time.
Right. Thank you so much for your responses. I'll now be passing the time to my other co-host for the final segment.
All right, hi everyone. So last but not least, we will be moving on to the last subtopic for today. I'm Gareth, one of your co-hosts for today's podcast, and I'll be bringing you through the subtopic, intersection of mental health and physical health. How does a cancer diagnosis affect the mental health? So Dr. Tan, I'd just like to pivot now to your perspective when treating cancer patients. In your experience, you must have encountered many cancer patients who have had varying experiences with cancer. Could you walk me through some of the perspective and mindsets you have seen patients develop after their cancer diagnosis?
Yeah, I mean, I've maybe touched on this topic a tiny bit on the previous two topics, subtopic discussion. The main thing here, just looking at this topic here, we're talking about mental and physical health. I personally think that there is a reciprocal relationship between physical and mental. I think we all know that the mind is linked to your body is linked to your mind. So I think when patient get diagnosed with cancer, it would impact on them. First thing first is mental, right? Because it's the first thing that comes to your mind. So they go through all this emotional turmoil, fear, uncertainty, stress. And then that's really important because it's really important to mitigate that. Because if you don't mitigate that mental aspect of that fear or uncertainty, it could impact on patient's immune system per se. Because if you have chronic stress and depression, it does impair immune function, and potentially lead to more problems down the track. And then with patient with poor mental health, it could also affect on them adhering to the treatment, so that you're drawn up for the patient. They won't follow through the entire course because their mind's like everywhere. So you got to mention that you have that, that rapport at the very beginning with the patient to know that, working as a team, because they're also part of the team, the patients. And then to get them in the right mindset, and strategies to really get to that would be integrated health. So we do have clinical psychologists support in the hospital that we get them to talk to. I mean, you might think that talking to someone or someone that is not your loved one may not be that beneficial, but a lot of my patients find that having that support from a clinical psychologist, because I think they attack the patient from a different standpoint. It triggers their mindset and teach them strategies to cope with that stress and uncertainty. So that's one important thing. The other thing is to talk about joining a group per se. So mental well-being. So I do treat a little bit of prostate cancer, and prostate cancer men, they tend to not talk, right? Like all men, they don't like to talk about what's going on. But then this is an open group, so they all join this group to share their treatment, journey, to share their symptoms. So the group of supportive men, and we also integrate that physical health in it as well, so that they join a gym session 3-4 times a week. So that it forms a really, really tight core group. And that is so important for them to know that there's actually other people who are also in the same shoe, and they're all going through this journey together. To have the support outside of your loved one and friends is so crucial. And then, so we talk about clinical psychologists, we talk about that group. And then the final thing is that just touching a little bit about the physical health side of things. So we'll talk about the mental health influencing the physical side of things, but then the physical side of things could be from a couple of different, I guess, different channels. So one of which you could feel sick and unwell from physical standpoint, from the cancer. So if you have cancer in your lung, for instance, or in your bowels, for instance, or in your brain, you get all those symptoms, right? Like constipation, pulling out blood, shortness of breath, headaches, seizures. There's that. And then you got to try and mitigate that with things. So first things to manage the symptoms first, address those symptoms. You put them on steroids or to try and stop the swelling in the brain so that you don't get so much headaches. And then you talk about the treatment. The treatment also comes with its own side effects. I usually print out a massive list for my patients so that they're completely aware of what to expect, the common side effects versus the uncommon side effects. And we put in certain strategies to mitigate those side effects. Because if you feel crap physically, it's going to impact on your mental well-being. And we do have a gym on site in one of our private centers. So a lot of men who comes in, they have a yes and no option to take to basically join the gym. And there's been lots of trials, even some local trials here in Australia to talk about that physical health component improve patients' overall cancer outcomes. So it's all intertwined and interlinked. So it's really important to understand the concept. It takes two to tango in this situation. You can't really just focus on the mental health. It has to be mental and physical. And you have to attack both segments independently.
Indeed, there are actually many ways that we can go about when to combat the issue of a cancer diagnosis. And you mentioned so many different methods, like be it going to the gym or seeking a therapist for emotional support. So when someone receives news that they have advanced cancer, among all these things that they have to consider, what do you think is the first thing they should do, or the most important that they should take into account first?
I think is to really let time set in. I think ultimately when you get diagnosed with cancer, you feel like very overwhelmed. But for the patient standpoint, they get that information overload because we talk about the cancer diagnosis, we talk about the timeline, we talk about treatment, we talk about side effects. So it's really important for patients to understand that everything takes time. You have to give yourself a bit of time to let the dust settle, to understand the diagnosis. Write down as many things as possible during the consultation, so that you can go back and read on. Some patient comes in and say, "Can I record this conversation?" I do allow it for some patients, but it's really not advisable. But I usually encourage them to write things down. I give them a lot of information to go home and read up on. And then it's important as a clinician to give them time. So by giving patient time means you do a follow-up consult. So before you start a treatment, you can always get the patient back in a couple of weeks' time to talk about their concerns again, answer the questions before you jump onto treatment. Because a lot of clinicians could just be like, all right, we're going to get straight on. But you got to really get the patient time to process, to go through it. And then it's not going to be impact on their outcome if you're just delaying treatment by a few days, So that's really, really important. I always tell my patient to focus on what's happening in front of them and take it a step at a time. Adjust to the expectation that it's happening, because as you know, we talk about different factors that comes in, they're juggling who should be home, who should be at work, and all this sort of stuff. You got to accept that expectation. And it's really important to get through the treatment. And the other thing to talk about is to have that bridge so that patient can always have an open communication with the healthcare team members. And that's very important.
Absolutely, yes. So moving on, Dr. Tan, for cancer patients who are definitely going through a lot of anxiety, how exactly can these mental health issues actually manifest, and what might they look like, or maybe both the surface level and within them? Yeah.
You can somewhat feel it when you see the patient. So again, it's about building that relationship with the patient. Once you build a relationship, you kind of know where they are, whether they are kind of someone who is more reserved, someone who's more open, someone who's always very happy. Someone's always very sad. You know, those sort of things you can kind of like gauge at the very first few consultations. And if there's any change in that, I mean, then you know, right? I mean, you pick that up, or the patient tells you that, you know, I feel really depressed. I feel like giving up. Those sort of things. And it's picking up those little cues, and I think that those little cues probably come from just day-to-day personal interaction with human beings and also with your patients. Some patients could be quite verbal when they talk. They'll tell you, you know, they're depressed. Sometimes you just have to pick that cue out from the patient and try and interrogate them a little bit more. You ask more specific questions, and whether or not they need support in the background. How are they coping at home? Sometimes I'll turn to the patient's partner, because it's really important you talk to the patient, but the partner is suffering in the background. So it's important to know as well. You read the room, you see the partner is really down, not making eye contact with you. At that point, I'll pause. I'll look at the patient's partner or the family members that is in the room with them. I'll be like, "How are you going? You know, is things going okay at home? How are the kids?" So those are really important things to pick up. And once you pick up, you just trigger off some sort of intervention. We talk about the support group. We talk about different strategies to manage stress and anxiety, like, you know, meditation and staying active, and getting a professional help like clinical psychologists. And then we just make sure that that's all put in play. And then once you put something in place, it's very important to follow up on whether or not it's improving. And then you have a gauge from there, and you just keep following them up slowly. That's how you really cope with it. You just have to read the cues. Yeah.
Yeah, so a cancer diagnosis is obviously a traumatic experience, not just for the patients, but their families as well. So when it comes to families, most of the time, people usually think of, the financial burdens as well as the emotional support that the family members can support the patients with. So do you think that there are other roles that are often overlooked that the loved ones can play in supporting the patient's mental health?
Well, I think the main thing is to be very understanding, because a lot of the time they're not clinical, though they're not medical professionals. So the patient's family do not tend to be able to put themselves in the patient's shoes, because there's that. Patients also feel burdensome to their family. You know, that is that feeling, and that's real. You just have to really understand and always have that. I think I've honed in so many times about communication. Let's always have that open communication and the trust factor amongst the family members themselves. To know and to, it's like a safe place for the patient to reach out when they need to reach out. I mean, I wouldn't say you need to have lots and lots of family members. It's not about the quantity; it's about the quality at the end of it. Like, you have to have a few core family members that you can go to. Make sure that they're well supported. Sometimes in the waiting room, they make friends with one another. So a few of my patients are kind of like make friends, and they kind of form their own little group outside of the treatment center. So those are things that you could put in place for the patients. There's also, you know, other kind of family help. Patients' primary physicians, so GPs who looks after the patient, and the patient's family is also very important, key. Because a lot of the time with specialists, we don't see them again for a few weeks' time. Whereas for them, they always have that engagement with their local doctor. So it's really important to get the local doctors in as well, so that more hands on deck, the better. So that it can kind of have a more holistic approach to the entire treatment paradigm for our patients.
Understand. Definitely, we need this multi-phased approach to really support cancer patients going through this tough time. So let's go back to the perspective of the medical team, shall we? At what point does anxiety become so severe that there's a need to escalate it to a mental health professional? And how will you make that decision that, you know, it is indeed the right choice to do?
Well, from my perspective, because I'm not a clinical psychologist or psychiatrist, so for me, my threshold is very low. So whenever I feel like the patient is needing some sort of support, I would just refer it on. Because there's no harm referring on. Obviously, you get the patient's blessing beforehand. Like, can you see? Do you want to go see a psychologist or psychiatrist to help, cope with your symptoms a bit better. Sometimes it could be a stigma for the patient. It's like, well, you're thinking I'm crazy. Or want me to go see the psychologist. But at the end, they understand it's like it's an impact on mental and physical well-being, as we discussed about extensively just now. So for me, referring patient on, I do it. I have a really low threshold, and then whenever I see red flags, I'll just refer on. Some minor cases like anxiety related to treatment, sometimes they need a little bit of calming pill to stay still for their radiation therapy, for instance. That one I'll manage myself, because that's not so impactful on the overall well-being. So those ones I can do myself. But then sometimes if they're talking about the other things like there's all these things that patients worried about, and if you think that it's all too much for them to handle, just refer on for them to talk to somebody.
For sure. It's always better to take the precautions than to wait to the last minute.
Yeah.
All right. So to end off our our third segment, for the viewers listening in, if they know someone who has cancer, what advice would you give to help them better support their loved ones?
I think at the end of the day, we talk about communication is the key, but really you just have to know and balance out all of the medical facts that patient get from the clinicians. And you have to balance that out with the patient's personal value. You got to balance that out with the person's emotional needs. And then once you have that, you build that trust, then we can all make an informed decision that align with the patient's goal of eradicating the cancer, not cause too much side effects, or cause some side effects, but it's manageable. It's just really important that it's not a like a bread and butter cookie cutter process for every single patient. It's very individualized. Different patients could have different treatment, even though they have the same cancer. That's the key. It's a very dynamic process. There's a lot of flexibility, and that ongoing communications between the clinicians, the patient's family, and other team members is so important, and it's a key of navigating the patients through this journey effectively.
All right. So thank you, Dr. Tan, for your responses. And actually, this marks the end of the third segment. So we have some spare time, and now we'll actually be moving on to our Q&A segment. So participants, please feel free to put in your questions in the Zoom chat box for Dr. Tan to answer.
Okay, I received a question via private text. Let me relate this question to Dr. Tan. So, Dr. Tan, I think you mentioned a little bit about immunotherapy, radiation therapy, as well as chemotherapy as the various treatment options available apart from surgery. Can you share with us a little bit more about what is immunotherapy and what are these various treatment options and how are they used?
Yeah, so I think it boils down. Let's just use staging as an example. So patients with stage 1 cancer, any cancer, stage 1, you can get away. Again, we're going to use the terminology of modality. So modality is the form of treatment. So we talk about single modality to multimodality. So as the stages goes up from stage 1 to stage 4, the modality also goes up. When you introduce more treatment modality, there is going to be more side effect profile for the patient. So stage 1 cancer, that's when you can get away with surgery or radiotherapy, and that's enough. Patient will be cured, right? And then stage 2, 3, you probably need 2 modalities. It could be a combination of surgery plus radiation, chemotherapy plus surgery. It could be any combination, depending on what sort of cancer we're dealing with. Or chemoradiotherapy followed by surgery, so trimodality. In patient with stage 4 disease, for instance, often the backbone will be chemotherapy or immunotherapy as the backbone, and then with radiotherapy to follow the symptomatic sites for pain control or for symptom control. So that's the general treatment outlook for our patients. Just talking about specific treatment options, that's the second question. So surgery, we all know surgery. You want to cut out the tumor as safely as you can to its entirety, so patients do not have to have additional treatment. Okay, so that's that. Radiotherapy is it's an external radiation, so it's actually delivered using a machine called linear accelerator. We basically shoot out photons or electron beams, and that would eradicate the cancer cells. It's completely non-invasive, so it's external. Patient will not get any pain. They just have to come in for daily treatment over a number period of time. It could range from like 1 day treatment to many weeks of treatment, and that's completely non-invasive. And the rationale behind the kill, I mean, you got a picture there of a cell structure, radiation is to eradicate the cancer cells by killing off the DNA within the cells. So that's how radiation works. With chemotherapy, it's a drug treatment. So depending on what sort of chemotherapy patients receive, there's multiple mode of action. The main one is to attack the cancer cells through DNA damage, once again. But there's other things as well, like some other chemo is used to starve the cancer of the blood vessels. So there's a few things. So there's different mode of action. And then finally, immunotherapy we talk about, and that's basically an immune therapy. So it's again drug treatment through the vein that basically induce your body's immune system to see the cancer cells as foreign. And that's what immune system works. Now, our body immune system get produced to attack and kill off foreign cells and foreign materials. So it's like a program thing. So they program the immune system to go attack the cancer cells.
Thank you, Dr. Tan, for sharing. I do see another question here in the chat. One of our listeners is asking, how do you determine what stage a cancer is? So let's take lung cancer, for example. How do you determine like a lung cancer is stage 1 or stage 2 or stage 3?
Yeah, that's a great question, Ballard. So we go through, there's a Bible, a Bible for cancer staging. It's called TNM staging. It's by HACC. We follow that, all of us clinicians. So I have it on an app on my phone, but just in a nutshell, just to give you a bit of understanding. So, so we talk about TNM. So T stands for tumor, N stands for nodal, and M stands for metastasis, right? So let's start from the worst case scenario. When you have metastasis, that's stage 4, right? When you have T and M, but no M, so no metastasis, so you have tumor and nodes. Depending on the size of the tumor or number of nodes involved, it will be between stage 2 and 3. Typically, stage 1 will only have T staging, so T only, but no N, so no nodal disease, no nodes, is lymph nodes involvement, and there's no metastasis, so there's no spreading to the other organs. So that's stage 1. But we follow that Bible, and it could be stage 1 to, so T1, T2, depending on the size of the tumor. So that's how we determine it. And it's a very I guess it's a robust TNM staging system that we use. It's available for all cancers. So every single patient, when they come in, will go through that little checkbox to stage them properly, because that's what determines the treatment.
Yep, definitely. I do see a question from Chloe. What made you choose to be an oncologist, and what was your journey like?
That's interesting. That's a very interesting question. So I've come a long way, and if I rewind myself back, 10, 15 years and say, do I see myself to be an oncologist in 10, 15 years time? The answer will probably be no. I think everything just happened in such a way for me along the way. So for those of you who don't know, you probably get it from my accent. I'm probably from your part of the world. I'm actually from Malaysia. But I moved here for high school and went to uni here. And then when I finished uni, like I stuck around. And obviously during that period when I was in uni, in medical school, there's been a couple of cancer deaths in our family. So that was very close to heart. I lost an auntie and then another uncle. And then there's that. And then, so I found that quite intriguing at that point in time. But then it wasn't really something that I wanted to do. And I always wanted to be an orthopedic surgeon. But then when I finished my medical school and I started work at World Perth Hospital, I did a few surgical terms, and then I was like, oh, this is not a right fit for me. So I then went down the physician pathway, so to be a general physician. But then that's going to be my second or third year out. I just been put in oncology rotation over and over again. I didn't really ask for it. The hospital gave me the rotations. And then after I've done a few rotations in oncology, I actually feel like this is probably my cup of tea. So I just pursued it from there. It took me a little while to get into training program, like all training programs. And then when I got on with it, I just never looked back. It's been pretty challenging along the way, dealing with all of this topic, but oncology is a field that is constantly advancing. There's so many drug treatments coming in. There's so many forms of radiotherapy coming in. So there's just a lot to grow in this field. So that's kind of like pivoting from that standpoint, and also from family experience. And then from there, one thing just led to another. And then we went away for a couple of years, around COVID time, to Canada, pursuing further fellowship opportunities. And then I'm back here, and I've not looked back. It's been a great field for me, very close to heart, and very fulfilling at the same time.
We have a question from the chat. How do you stay motivated when facing difficult cases, and especially when medicine is uncertain, outcomes are not certain, and treatments may not go according to plan? How do you deal with that uncertainty?
Yeah, it's very defeating. Sometimes, like when we go through treatment journey with our patients, at some point, I mean, if they have late stages cancer, it's going to get them one day, right? You just hope that every single time when they have a scan, that the scan is clear, for instance, or they don't have any active disease going on. So you're right, outcome is always uncertain. I always tell my patient, you got to take it a step at a time. We'll cross the bridge when we get there. We do a scan every 6, 8, 12 weeks, and we just do it at a step at a time. And then a lot of the time when we talk about treatment outcomes, we base off literature. So there's some new drug treatment that can improve, say, cancer survival by 30 to 50%. You just follow the trials and tell the patient that is the numbers, and that's what we expect. Some patients do meet that, but that's median. We always tell patients median, because patient can not do so well, or patient can do very well and exceed what we expect. So it's very difficult, but I mean, the key is to take it a step at a time as you go, and make sure that patients fully informed on what's going on. So that's the question from Jali, and then I can actually see the questions too. And the next one's from Jen. Do you mind if I'll read up the questions so that it's
Yep, no worries.
might be quick, because I can see them, might be quicker that way. So when can follow-up care look like after cancer remission? So when patients in remission, so let's just use lung cancer, for instance. When a patient has been successfully treated, we catch up with them 3-6 monthly with scans up to about 2 years, and then I stretch it out to 9 months or 12 months scans. And then I usually let them go at 5 years. And we do have patients who live up to 5 years, and I discharge them from clinic. And that's a great feeling. Ultimately, after they've been discharged from our clinic, we get them to watch out for signs and symptoms of lung cancer recurrence, even though the risk is very small at that point. But they should investigate any concerning symptoms at its own merits. And that will be guided by the patient's general practitioners. So we'll have a very thorough notes when I discharge my patient to say, you have to investigate any potential symptomology or symptoms at its own merits, and also be mindful and refer the patient back if there's any clinical concerns. So that's questions, Jen. Yeah, misdiagnosis. Yeah, I mean, it's very uncommon nowadays. The way we mitigate misdiagnosis is by discussing all our cases in a meeting. So all our cancer diagnoses, they get discussed in a multidisciplinary meeting. And a multidisciplinary meeting consists of radiation oncologists, medical oncologists, surgeons, the radiologists, the pathologists. So it's a really core group. It's a big meeting of about 5 to 10 people, and we go through all of the patients' cases before we come down to diagnosis. So when the patient comes through to our clinic, they already have all their pathology sent through to us and so on. And so we already know that. And then we'll be discussing the case again. So there's another documentation and then and treatment recommendation. So it's a few checkpoints along the way before patient comes into our clinic to avoid that misdiagnosis issue. Yeah, with late stages, that's a question from Ashley. That's a great question. That is important. It's important to give patient that little hope, even though in their late stages of their cancer, just so that they're aware of the fact that we're doing something for them before they really give up on everything. This is probably more important for patients who are younger. Like I said, I've treated, in the past month or so, I've treated a few younger patients, and that's really, really hit home for me. For instance, there's a patient I saw in his 40s, late stages of cancer, not doing very well at all, but is keen to have any treatment possible. You just want to make sure that it's a fine balance, that whatever treatment you offer the patient is not going to impact on their quality more. And if they feel like you're doing something, you just have to jolly them along. So I offered the patient a bit of treatment at their later stages, knowing that they're not going to survive more than 2 months, but I still offer it to them, just to give them that hope to know that we're actually doing something for them. And that's enough to appease them mentally, and that it connects physically. So I know that's not the goal, but it's case by case scenario. So sometimes if the patient needs that hope, you make sure that you can deliver it safely, and if you can do it, you do it.
Okay, I think there's no more questions. So we'll end our sharing here. Thank you so much, participants, for tuning in.
Once again, thank you, Dr. Tan, for joining us today, and participants for spending your Sunday morning here with us. Please look out for our other initiatives and reach out to us if anything interests you. Thank you and have a great day ahead.
Thank you, Darius and the team. It's been an absolute pleasure to be here this morning talking to you guys about this topic. You guys have a good Sunday.